So, hello and welcome back. So, as I alluded to in the previous screencast in this series, we need to differentiate autoimmune pancreatitis from chronic pancreatitis in certain clinical scenarios. This is done using imaging, and today's talk is going to be about that. So, this is approach to vomiting and abdominal pain, part 3.1b. We're going to discuss how autoimmune pancreatitis is different from other forms of chronic pancreatitis on imaging. The overview will get a broad overview. We'll get a broad overview of the parenchymal and duct changes in autoimmune pancreatitis and other forms of chronic pancreatitis. Then we'll list the differences between type 1 and type 2 autoimmune pancreatitis on imaging, or rather the lack of differences. Then we'll talk about parenchymal pancreatic changes and correlate them with the pathology that is seen. So we'll talk about differences based on the different distribution of tissue fibrosis and the lack of tissue contracture. We'll describe the rectangular tail sign, also called the cut tail sign. We'll talk about pancreatic ductal alterations and correlate them with pathology. Then we'll talk about the evidence for the usage of imaging in differentiating autoimmune pancreatitis from chronic pancreatitis and the utility of the signs and findings that we've described before that. Okay, so getting right into it, autoimmune pancreatitis versus other forms of chronic pancreatitis. So this was the general imaging characteristics of chronic pancreatitis that we had described on non-contrast imaging and contrast imaging. We had found that there were basically five imaging findings in the parenchyma of patients with chronic pancreatitis. There was an alteration in pancreatic parenchymal signal intensity on T1 and T2, and then there were various manifestations of basically tissue contracture resulting in reduction in the volume of the gland and an increase in the size of the duct. So naturally, since we're talking about storiform fibrosis here, those changes are no longer valid. So we'll just remove those. Similarly, duct dilatation due to duct stenosis was due to fibrosis around the duct of the parenchyma in chronic pancreatitis. And similarly, that stasis of pancreatic secretions in those dilated ducts was an upstream of those stenoses was what was resulting in stone formation. So that is also the cat can be removed. Um, the other changes, however, are going to remain. So we can rearrange our changes in the terms of autoimmune pancreatitis as follows. So essentially, we can replace this framework with a new framework. That is, we find the same alterations in parenchymal intensity or radiodensity, but we may have mass-like lesions within the pancreatic parenchyma. However, there is no tissue contracture. Similarly, we will have the same enhancement abnormalities and we may get some enhancement of the pancreatic duct. However, the duct is usually normal in size, and if there is a stricture, the stricture is long and as we'll see, multifocal. So there's an important caveat to all of this. Type 1 versus type 2 clinical autoimmune pancreatitis is actually a clinical diagnosis. It's based on the pretest probability of what is the expected histopathology on a biopsy sample. That is whether it's likely to be IgG4 related disease on the pancreatic biopsy, or is it likely to be periductal pancreatitis. This is what we'll discuss in the next and the last video in this subseries. However, radiologically, these two entities are actually indistinguishable as long as the clinical presentation is the same. So for the purpose of describing imaging changes, we will refer to both entities under the umbrella term autoimmune pancreatitis. Now, something that has to be noted is, as I have discussed in part 3 of the series, type 1 autoimmune pancreatitis is more likely to present with obstructive jaundice due to mass formation in the head of the pancreas, and thus it is likely to present slightly differently. And similarly, type 2 is more likely to present as acute pancreatitis, and thus the corresponding changes are inferred on histopath clinically. That is when we use the terms type 1 and type 2 autoimmune pancreatitis. These terms, however, are replaced with the formal terms IgG4 related and periductal pancreatitis once histopath is available, if histopath is available. Obviously, in all clinical scenarios, that may not be available. So imaging findings, again, to reiterate, do not carry enough diagnostic utility to enough diagnostic utility in differentiating type 1 versus type 2 autoimmune pancreatitis. Any such differentiation thus must be based on clinical features, and imaging findings are just used to differentiate autoimmune pancreatitis from other forms of chronic pancreatitis or mass lesions, as the imaging might indicate. So naturally, there is some overlap between the clinical features of type 1 and type 2 autoimmune pancreatitis, but there is very significant overlap in the radiological features of type 1 versus type 2 autoimmune pancreatitis. So imaging should not be used to differentiate between these two types of autoimmune pancreatitis. Okay, now coming to changes in autoimmune pancreatitis versus chronic pancreatitis. So we'll talk about parenchymal changes in autoimmune pancreatitis versus chronic pancreatitis, and this is distinguished by the basic principle that the distribution of fibrosis and the absence of fibrosis related tissue contracture are typical for autoimmune pancreatitis vis-a-vis chronic pancreatitis. So on the right of the screen, I have a what we've already seen, that is a axial TV1 weighted image of a patient with chronic pancreatitis, and we've already seen that there is a subtle decrease in signal intensity of the pancreatic tail, which I've highlighted in blue, while the rest of the pancreatic gland is normal. So this area is normal and the rest of the gland is has decreased intensity. Now in this image, again, this is again an axial T1 weighted spoiled GRE image that has been fat suppressed. So in this, we again find a decrease in the T1 weighted signal within portions of the gland. Now, importantly, the most important thing is that the distribution is very odd. It's not, affecting one particular area of the gland. It seems to be slightly multifocal. And something that is very, very important to notice is that in addition to the subtle decrease in the intensity, you also find that the pancreatic duct is intact. So you can see the pancreatic duct essentially completely maintained within the parenchyma of the gland, again indicating the lack of fibrosis related tissue distortion. Now, in this T2 weighted image that again we've seen before, that is an axial T2 weighted HIST image, there is a subtle increase in the signal intensity of the pancreatic tail, which I've highlighted with an arrow and with the red markings. There is also no rim of hypoenhancement surrounding the area of high signal. On the other hand, see this image. So in this image, again, there is an increase in the T2 weighted signal from an area of the pancreas, which I've highlighted in teal. And surrounding that area, there's a rim of hypointense tissue that I have highlighted in yellow. So this is autoimmune pancreatitis, and as I've just said, there is a subtle increase in the signal intensity through most of the pancreas, with normal pancreatic duct coursing through the pancreas. Now, the high signal region is surrounded by a rim of high dense signal, that is basically the capsule of the fibrous gland. Now, coming to a relatively specific finding that is primarily been described in type 1 autoimmune pancreatitis, that is the rectangular pancreatic tail or the cut tail sign. However, like I said, does not differentiate type 1 from type 2. This is an unenhanced T1 weighted MRI axial section of the abdomen, and I've just highlighted what is called the cut tail sign. It's almost as if someone's taken a knife and cut off the edges of the gland. So there's a otherwise sausage-like swelling of the gland with straight margins that appear to have been cut with a knife, and that gives a rectangular silhouette to the tail. And this has been called the cut tail sign. Now coming to the pancreatic duct changes in autoimmune pancreatitis versus chronic pancreatitis. So this is primarily distinguished by the presence of hyperenhancement in the duct wall and the absence of, again, fibrosis related tissue contracture. So this is what we call the enhanced duct sign. So both are contrast enhanced CT scans. You see that the enhancement of the wall of the main pancreatic duct is more than that of the rest of the pancreas. It's almost as if the main pancreatic duct has been highlighted. Similarly, you see a similar hyper enhancement in the wall of the common bile duct that I've shaded in green. So this indicates the presence of coexisting sclerosing cholangitis that would again increase the possibility of it being autoimmune pancreatitis. And this finding, however, could indicate that it is type 1 autoimmune pancreatitis over type 2. That is the presence of hyperenhancement in the common bile duct. So this is called the enhanced duct sign. So in summary, autoimmune pancreatitis can be differentiated from chronic pancreatitis, definitely. But this is based on the clinical picture and the imaging findings. So just to formalize the evidence for the findings that I've just described, we'll just go ahead and enumerate the data. So duct findings are better at differentiating autoimmune pancreatitis from chronic pancreatitis. There are 3 duct findings that have a pooled sensitivity ranging from 44% to 71% and specificity of 92%. That means the LR positivity of these findings is 5.5 to 9 times. So as we discussed previously, the LR positivity of some of the findings in autoimmune pancreatitis that help it differentiate it from pancreatic neoplastic lesions is actually significantly more. Specifically, the lack of upstream duct dilatation has an LR positivity reaching 18. So definitely imaging is better at differentiating autoimmune pancreatitis from other mass forming lesions within the pancreas, but it is still useful in differentiating autoimmune pancreatitis from chronic pancreatitis. Now, another caveat is that these findings have actually been described on endoscopic ultrasonography, which is obviously done by gastroenterologists. So the utility on routine conventional imaging is something that needs further appraisal and but because of the mechanistic overlap and the similar findings, there is a correlation. So the three findings that are most important are visible side duct branches originating from a narrowed main pancreatic duct. So we've seen that in chronic pancreatitis, usually dilated branches are upstream of a narrow segment of the main pancreatic duct because of back pressure. So in this case, the visible side duct branches are originating from the narrowed area of the main pancreatic duct. Second is the absence of upstream dilatation of the main pancreatic duct naturally. And third is the presence of long and multiple strictures involving the main pancreatic duct. Now, importantly, since this is based on endoscopic ultrasonography, this is not does not comment about the utility of the enhanced duct sign. But the enhanced duct sign, at least on face value, has high specificity, although this has not been formally verified. However, again, in the absence of an alternate explanation, for example, a neoplasm of the pancreas, um, diffuse uniform, enhancement along the wall of the main pancreatic duct is very specific. So in this screencast, we've talked about the following. We've compared autoimmune pancreatitis to other forms of chronic pancreatitis in terms of its imaging findings. I've given an overview of the parenchymal and duct changes in autoimmune pancreatitis and other forms of chronic pancreatitis. In particular, I've talked about the differences between type 1 and type 2 autoimmune pancreatitis on imaging, or rather, I've talked about the lack of differences between those two entities. Then I've talked about pancreatic parenchymal alterations and we've correlated them with pathology. The differences were based on distribution of tissue fibrosis and the lack of tissue contracture, which is associated with normal fibrosis, but not with storiform fibrosis that you see in IgG4 related disease. Then we talked about the rectangular pancreatic tail sign, also called the cut tail sign. We saw the image, and now I hope it is clear to you what that entails. We've talked about pancreatic ductal alterations and we've correlated them with pathology. So finally, we finished with evidence for the usage of imaging in differentiating autoimmune pancreatitis from chronic pancreatitis. So before I finish, there is an additional thing that we need to discuss. Uh, I've shown you MRI images, shown you CT images, but when you have a patient, often you have one or the other. So what do you decide? Do you prefer an MRI or do you prefer a CT in the differentiation of autoimmune pancreatitis from other forms of chronic pancreatitis or from mass forming lesion? So again, naturally, the choice depends on the clinical and radiological context in which you are evaluating the patient. So the clinical context matters. So in a recent comparative meta-analysis, which I've given a citation to below, there was a comparison between CT and MRI in terms of diagnostic accuracy in autoimmune pancreatitis. So overall, that is in both differentiating autoimmune pancreatitis from chronic pancreatitis and from mass forming lesions, MRI had a significantly higher sensitivity than CT. So this was around 84% as compared to 59% with CT. But there was similar specificity. So you're more likely to pick up something on an MRI, but once you do pick it up, the LR positivity is around the same. Now, for mass forming autoimmune pancreatitis, discrimination between mass forming AIP and pancreatic adenocarcinoma, the sensitivity was again higher for MRI versus CT, but this time the difference was not as much. Okay, it was 76% versus 50%, as you would expect because there is a mass there. But specificity was similar for both methods. That was 97 versus 98%. So overall, MRI is always more sensitive, much more so when differentiating autoimmune pancreatitis from chronic pancreatitis, but the specificity usually remains the same. So that brings me to the end of this screencast. In the next discussion, we will be talking about the evaluation of histopathological findings and their utility in differentiating type 1 and type 2 autoimmune pancreatitis. And as I've already discussed, in that situation, we then start calling it IgG4 related autoimmune pancreatitis and inflammatory periductal or idiopathic periductal pancreatitis. Okay, so thank you for watching. I'll see you next time.